Well, hello everyone, and welcome to our seminar on responsible AI in medicine. So we're holding this seminar as part of the activities of the Samueli Initiative for Responsible AI in Medicine in Tel Aviv University. And we've been having these meetings over the past, 16 months or so, with different participants from different countries and presenters from different areas in the world. And so we chose English as the language of this seminar, so it's quite accessible. And it's our habit to try and connect concepts and how things are operationalized. So kind of field work in a way, either medical or technical, with the concepts from philosophy, from law, from other social sciences. And I think today is going to be quite an interesting and important part of our endeavor, because our presenter today, which we had a short opportunity to kind of get to know how he looks at things and what he's doing, he combines both the clinical medical doctor perspective, but also the entrepreneurial perspective and the digital medicine perspective, so to speak. And we think that when we talk about ethics, it's quite important that it's not just the philosophers and the lawyers imposing their wonderful notions on others, but rather that people who are dealing with medical issues and with technology also think about those issues. And I'm thinking we might have an additional perspective today of how Dr. Charlap, our guest, thinks about responsibility in AI in medicine. So I'd like to thank again our sponsors, the Samueli Initiative, the Tel Aviv University, Dr. Amir Tal, who's been quite helpful with getting us to have all those meetings and getting the amazing guests that we have in this seminar. And now we are going to hear from you, Stephen. So I'm just going to say Stephen is a medical doctor. He has a master's in business administration. He's also the CEO of SOAP Health. And really, the floor is yours now, Stephen. And I'm looking forward for a fruitful discussion.
Okay, thank you very much. So I am very much looking forward to your questions at the end. Let's get started with a very quick survey. How many of you think that AI should replace doctors? Can you show by putting should replace doctors by put up a yellow hand if you think that AI should replace doctors? Okay, so I don't see any yellow hands.
Can I answer?
Great. Anybody?
It shouldn't replace the physician. It should help and support them for decision making and smart decision making.
No, I hear what you're saying, but that's the question. Let's see how we vote by the time I finish this lecture. So I'm going to talk about three things. I'm going to talk about, should AI replace doctors? Can AI replace doctors? And will AI replace doctors? Before I start, let me say that this lecture is in memory of my brother Shlomo. Shlomo was a cardiologist who was misdiagnosed and lost his life to that misdiagnosis. Let me just try to share my screen here. Can you see my screen?
Yes.
Okay. Now let's see if I can advance my screen. Okay. So Shlomo's colleagues failed to identify our family risk for cancer, which led to Shlomo being diagnosed with a very late stage cancer. It not only happened to Shlomo, and by the way, my real name is Shmuel because I was born in Israel, but it also happened to my wife's best friend, also a physician who actually trained to be a doctor in Israel, lived in Miami. It took doctors 18 months to diagnose her cancer, even though she previously had another cancer, and she also died from that cancer. and I almost died from a heart disease misdiagnosis. So you could call me one of the most obsessed people on earth with preventing misdiagnosis. Now, let's talk about how big a problem that is. In the United States alone, okay, the two most common killers in general are heart disease and cancer. They kill about 600,000 each. Heart disease a little bit more than cancer. Misdiagnosis, and the most common misdiagnosis is early cancers and heart diseases, alone kill 400,000 people and permanently disable another 400,000 people. So that's 800,000 people. And it's believed that the cost of that misdiagnosis is over $1 trillion, or 25% of US healthcare costs. And according to the US National Academy of Medicine, the number one thing that's likely to happen to everybody is to experience a misdiagnosis. So stop and think about that. It is estimated that there is a misdiagnosis basically every 3.6 seconds, and that somebody dies or disabled every 8 seconds. In addition, here in the United States, it results, according to the American Medical Association, in 65% of doctors being sued for malpractice by the age of 55. And for every doctor over the age of 40, there's one malpractice suit. So unfortunately, doctors are making somewhere between 12 to 18 million errors, and the diagnostic error rate is between 5 and 15%. Now let's talk about why doctors, human doctors, are making these errors, okay? We've all heard about physician burnout, okay? That's both a cause of error and a result of errors. But in addition, we know that physicians, about a quarter of them are suffering from depression, 10% think about suicide, 1% actually attempted suicide. We also now have studies that show beyond a doubt something called decision fatigue, which is the most important takeaway from this lecture is always go to the doctor or the surgeon first thing in the morning, because as the day goes on, they become less conscientious and their decision-making becomes flawed. In fact, in a study of 19,000 women, it was shown that doctors were less likely to refer the women for cancer screenings in the afternoon than the morning. And in another study, it was shown that doctors are less likely to write prescriptions for statins in the afternoon than in the morning. And so decision fatigue is a real problem. Another real problem is financial incentives. Doctors are not financially incentivized to prevent disease, or for that matter, to detect disease early. In fact, one could cynically argue that a doctor that fails to detect a diagnosis early makes more money by seeing the patient again and diagnosing it later. Again, that's a cynical view, but it's also a realistic view. Also, doctors are distracted. They are constrained by time, okay? They want to make a certain amount of money. And so they work very fast in order to make that money, and that speed can contribute to mistakes. And of course, another big cause of mistakes is knowledge gaps. Medical knowledge is simply beyond the capacity of the human brain to understand everything they need to know, particularly in primary care, where a primary care doctor needs to know a little bit about everything and a lot about some things. Interesting enough, 150 plus years ago, the founder of the Mayo Clinic in Minnesota said that medical knowledge already far surpassed any human being from knowing all of it, 150 plus years ago. So this issue of human error. Now let's talk about some of the other challenges of human doctors. You have to make an appointment. They're not there when you want them. They're there when they're available, usually 5 days a week, 8 hours a day, and you are competing against other patients for that doctor's time and attention. So not particularly convenient. Oftentimes you have to take time off from work. You have to travel there. You have to travel back. Not convenient. And of course, not inexpensive. The average doctor visit is definitely at least 3 figures. Okay, $100 or more. So there are many challenges with human doctors. But let's talk about the worst part of the story. You're saying, how could there be a worse part of the story? Well, there is. According to the National Association of Community Healthcare Centers in the US, over 100 million Americans don't have access to primary care. Worldwide, that number is 4.5 billion. So more than half of the world's population doesn't even have access to primary care. In addition, doctors are not choosing to go into primary care. And so what are we doing here in the United States? We're pushing down the responsibilities to nurse practitioners, PAs that used to be called physician assistants, now call themselves physician associates. And even in countries like Canada and the UK, they're now allowing pharmacists to prescribe medications. So if doctors trained with 4 years of medical school typically, and at least 3 years of residency, are making these number of mistakes and facing these numbers of challenges, what do we expect is going to happen with nurse practitioners, which, by the way, are now getting sued at the highest rate ever, are also making lots of mistakes, and are having a very tough time. In fact, I'll just tell you an anecdote. I was invited to speak to a group of minority students at a local university in Florida where I live. And another person was invited, a physician assistant. And she gets up and she talks about how she went to the school and how she got into physician assistant school, and now she's working as a physician assistant, and she does this and this, that, and she's very optimistic and very positive, and so on and so forth. And, and I'm going, oh, great, she loves what she does, blah, 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 blah. I get up and say, I don't want to be the party pooper here, but medicine is really broken. There's a lot of very serious issues. And here in the United States, we pay more, we get less. It's only really good if you're really, really sick and you need the most advanced sciences. That's where the United States shines. But in general primary care, we're not even ranked in the top 10 across the world. You better think twice before becoming a doctor, because it's not what you think it is. And then she gets up again, and I'm afraid she's going to say, don't listen to him, he's just being negative. And she gets up and she says, everything he just said is true. And I'm like, what? You were so positive. And I turned to her, I said, you were so positive. She said, yeah, I'm a positive person. I wanted to put a positive spin on it. But all the stuff you just said about how bad it is to be in medicine is 100% true. This is the reality of the situation. I, 10 years ago, as I mentioned, lost my brother Shlomo. I was on my second entrepreneurial effort, actually running a state-of-the-art primary prevention medical center, which was doing unbelievable things clinically. But here in the United States, we don't pay for prevention, so we're struggling financially. When my brother got diagnosed, I became one of his caregivers during his last few months of life. And when he passed away, I closed my second business and I went back to school at Stanford. I spent 3 years there, 1 year studying genetics, 1 year part of a research project that looked at whether Stanford doctors know how to do proper risk assessments. And the 3rd year, Stanford gave me a grant to build an early prototype. I then left Stanford and spent 2 years at Harvard, where I got money from Harvard to do a small pilot. What was I searching for? I was searching for a solution of how to prevent misdiagnosis. And you'll say, why did it take you 5 years? And I'll tell you, because I didn't have 10 years. Because the more I dug into it, the more I understood the challenges that were faced by not only primary care, but internal medicine subspecialties, and most doctors. In fact, my company now sells to a lot of concierge physicians who only have 200-300 patients in their panel. And you know what the most common comment from them is? I'm too busy. Too busy taking care of only 200-300 patients. While most doctors are taking care of panels of 2,000 to 3,000 patients. And so, after studying the problem religiously for many years, looking at malpractice literature, okay, why doctors were making mistakes, what was contributing to it, what could be done about it, what was resulting in misdiagnosis, it turned out the number one reason for misdiagnosis was failure to identify risk factors. Risk factors that were present but ignored. The number 2 was failure to generate a large enough differential diagnosis, list of possible diagnoses. Number 3, failure to order the appropriate test. Number 4, failure to make the appropriate referral. So I said, boy, that's just one set of reasons for misdiagnosis. I gave you at the beginning of this lecture many other reasons, from decision fatigue, time constraints, knowledge gaps. I said, this is going to be a tough nut to crack. But I said, in memory of Shlomo, I'm going to try. And so I founded a company almost 5 years ago called Soap Health. And unlike most entrepreneurs, I said, I'm not going to release this to the market as an MVP because patients' lives are at stake. I'm not going to release this to the market until it accomplishes a minimal level of greatness. And so I set out to build initially 3 products, which you see on the screen here. The first one is called the Perfect Medical Interviewer. Why? Because the biggest impact in medicine over the last 40, 50 years is how little time doctors spend with patients. And there's no magic. Studies show that the less time they spend with the patient, the less information they collect, and the less information they collect, the more likely they are to make a mistake. Now, there's no way to get doctors to spend extra time with patients. There's nobody to pay for that, except in concierge practices, which we'll discuss later because that's a whole issue in and of itself. And so we built the Perfect Medical Interviewer. We patented it, we clinically validated it at Stanford, and it's now in the market. What does it do? It's a talking digital human. It can carry on 100% voice-based conversation with the patient, back and forth. How can it do that? Well, over the 9+ years I worked on this, I built a database of over 80,000 phrases, words that include slang and idioms and synonyms for over 2,500 unique symptoms. So for example, if the patient says, I am praying to the porcelain god, our genie, the interviewer, knows the patient is vomiting. If the patient says, I have the Aztec 2-step, Genie knows they've got diarrhea. They say, I broke my water, Genie knows they have labor contractions. Trained to be exhaustive. This proprietary database has every possible representation of vomiting, diarrhea, abdominal pain, headache, etc., including suicide and other mental health issues. It has been shown in a recent study in 100% of patients to collect information missed by the doctor. 100%. 2 out of 3 patients to identify risk factors missed by the doctor. But that's not what makes it great. What makes it great is that it collects more truthful information. What does that mean? A study in the United States over 2 years ago showed that more than 50% of Americans lied to their doctors about things that might embarrass them. And just this week, yesterday, I published something on LinkedIn. A new study from just last week showed that not only do patients lie to their doctors about things that might embarrass them, they are smart to do so because the doctors judge them negatively based on the truth. So not only is it good to lie to your doctor because your doctor is going to think less of you, and that impacts the way the doctor treats you. That was just shown in a study. So why are people more truthful when they talk to a digital human? Because the brain lights up differently. Because they're not afraid of being judged. Because they don't feel the need to make an impression or manage their reputations. So they are more truthful. Not only does the study show they're more truthful, they're more talkative. They say more words to a digital human than they say to a human. And you know what else a digital human doesn't do? It doesn't cut them off. So they get to speak. We also made our application collect more accurate information. How did we do that? We use intuitive imagery. We have an artist on staff, and we create all of our own images. And we work on those images very carefully. So, for example, I just approved an image yesterday for urinary incontinence. The picture was somebody holding in front of their pants, their hands, with what looks like liquid and a little drop coming from it, meaning that they leaked. That's intuitive imagery. How else do we ensure accuracy? By reflecting answers back to the patient. What does that mean? When you go to a restaurant and there's a good waiter, when they take a long order, is going to repeat the order back to you and say, did I get it right? In fact, studies show that waiters that repeat the order back to you get higher tips. Why do they get higher tips? 2 reasons. One, you know, the waiter wanted to make sure he or she got the right order. And 2, you actually get the food you ordered and don't have to wait an extra 20 minutes to get the food you didn't order. So we reflect the answers back to the user. And lastly, we use a combination of hard coding as well as LLM, hard coding and LLM to interview the patient. So we are doing an exhaustive interview, and we are collecting all types of information from 3-generation family history. Now, this is not a fast interview. This is not meant to guess your disease by asking you 5 to 7 to 9 minutes worth of questions. This interview can take 25, 45 minutes, even an hour. One patient spent 2 hours with it. Now, we interviewed doctors, and they told us something very, very, very concerning. Human doctors told us they don't want more information on their patients. We got a grant from the National Institute of Health to go out and interview over 100 doctors. And we heard this consistently. We don't want more information on our patients. And it was like, what? And we asked them why. And they said, you know what? I don't have time to deal with the information I already collect on my patient. I definitely won't have time for more information. Oy vey. And then they gave a second reason, which was even a bigger oy vey. They said that information might include something important, and I might miss it and then I'll be held liable for it. So I'd rather not collect it in the first place. Now, I've heard this for many years, but the people who work with me walk away when doctors say that in shock and say, what kind of doctor would ever say something like that? Well, the bad news is many doctors say that. Many. In major health systems, we've heard it. And here's something else they told us. When patients provide information on a paper form, like a medical history form, or they fill out a digital form, the doctors told us they don't read it word for word. They scan it with their eyes. And they admit it that they miss up to 40% of what's written. 40%. And if they admit to 40%, let's make it 60%. And I've experienced this myself where the doctor didn't read anything I wrote. So, as I also told you, when I was at Stanford, we did a study to look at whether Stanford doctors knew how to even do a proper risk assessment. They didn't. So the next thing we built is the world's most comprehensive risk assessment. We took 16 sets of medical association guidelines, over 500 algorithms. We hard-coded the algorithms, and we do the world's most exhaustive risk assessment, looking at hereditary, lifestyle, social determinants, preventive measure utilization, vaccination history, etc., to make sure that we don't miss risk factors. And then we also generate a differential diagnosis using a large language model. And based on our prompt engineering and some trade secrets, we are reporting diagnostic rates above the Mayo Clinic. Above the Mayo Clinic, which is considered the bastion of diagnostic accuracy. We've created new ways of showing family disease risk. You see this little picture on the middle box? That circle there, that's patented, a new way of illustrating family disease risk. And then finally, we put it all in a medical note and we push it to the doctor in a way that's easy for the doctor to review, not miss anything. And we use the large language model to support the doctor through a whole bunch of different things. I'm not going to talk about that now. There is nothing like this. Just to show you very quickly what the workflow is, patient schedules an appointment, they get a link with a text or an email, they click on the link, they authenticate themselves, they consent, and they're talking to the digital human. If they don't want to talk to the digital human, they can change it to the digital human only speaks to them. If they don't want the digital human to speak, they change it where they're using it like a regular application, tapping and writing on the screen. And this process goes through iterations. We've done a number of studies at different places, from Stanford to practices to even in the United Kingdom. Okay, this was a study that was published by Stanford. And again, we've gotten unbelievable results in different clinical studies, high completion rates, catching things the doctors miss, even generating additional revenue by catching additional medical complexity. Okay. Now, let's talk about the ethics and the responsibility of using AI. AI is a tool. Like any tool, it must be used properly. It's okay to use a hammer to knock in a nail. It would be silly to use a hammer to break an egg. People who take AI and say, okay, let me go find a use case for it, are proverbially using the tail to wag the dog. You need to understand the problem. It took me at least 5 years to have a reasonable understanding of the challenges that doctors face. 5 years. And it wasn't my first startup. I ran my first startup for 19 years from scratch and sold it in a bidding war. I knew what I was doing, and it still took me 5 years. And I started the company because I said, I'm getting older, I need to get going. So it took a long time to understand what needed to be solved. And so when it comes to AI, the responsible use of AI is first understand the problem you're trying to solve, not just from your own head, but from published literature, from hundreds of conversations with people, to truly understand not only the problem, because everybody says you got to solve a problem, but to help whoever you're trying to help do a job. Okay? People buy things that help them do their job or do their job better. And so you have to think about the use of AI in an appropriate fashion. Now, I talked at the beginning of this lecture, okay, should AI replace doctors? I'm a big science fiction watcher, and virtually every science fiction TV show and movie today has AI having replaced human doctors. The one exception is a TV show called The Ark, A-R-K, where the doctor was still human, but she got hooked on pain medication. And that was 3 episodes of her getting hooked and her getting unhooked off the pain medication. So that's why they kept her a doctor. But everybody else thinks that AI in the future will be medicine. Now, why does that even make sense for AI to replace doctors? Because AI can consider 28,000 plus diagnoses, when human doctors have told me that if you ask them to name all the diagnoses they can name, they will never break 2,000. Many of them not even sure they'll break 1,000. Yet there are 28,000 plus diagnoses, including 7,000 to 10,000 rare diagnoses that most doctors have never seen in their lifetime. There are over 2,500 symptoms. Okay, there are hundreds of tests and signs, like McBurney sign for appendicitis, that most doctors don't even know. And they've told me almost to the person that they don't even remember those signs and tests anymore. And of course, they're rushed. They're not always accessible, definitely not 24/7, and they're expensive. So from my perspective, if AI could replace a human doctor who's prone to error, okay, prone to error, making 5 to 15% error rates, why wouldn't I want to get the best possible care? What can humans do that AI can't do? The human can hold your hand. Today, the human can examine you, and we don't yet have the capability to doing examinations at home. But companies are working on it. Tidal Care is selling kits that allow the exam to be done at home by a doctor away, but there are companies working on digital stethoscopes, okay, handheld ultrasounds that could be used by an everyday person. Of course, it's still expensive, but imagine if you could buy a handheld ultrasound at home that was a large surface area, and you could put it over your body and it can tell you if your spleen is enlarged, if your liver is enlarged, if your abdomen is hot, if your bowel sounds are normal or abnormal, if there's something pulsating, if there's something sticking out, okay? If it can listen to lung sounds, if it can look in your eyes, you can put on glasses that examine your eyes, etc. It doesn't exist today. So only human doctors can do the physical exam, or human physician assistants, human nurse practitioners, even human nurses. So human doctors cannot yet be replaced. But that's not the question I'm asking. The question I'm asking is, if they could be replaced, should they? And the answer is simple. With 4.5 billion people across the planet not even having access to it, if we could provide AI cost effectively, which is also an issue in and of itself, why wouldn't we allow AI to replace doctors? Okay? And does there need to be a human in the loop? Absolutely. But that human doesn't need to be a quote unquote doctor. And I'll tell you why. I used to drive a Mercedes SUV. One day my wife was driving it, 1 o'clock in the morning. It stopped dead in the middle of the highway. The computer failed. Computers fail. AI is still basically a computer. Computers fail. We do need somebody overseeing it to make sure it neither fails nor acts inappropriately. But again, it doesn't have to be a doctor. Okay, so let's talk about should. Okay, can it? Okay, so we talked about today it cannot. Now, the other reason people say it cannot is because of liability and regulatory reasons, right? Let's talk about liability issues. There are 4 standards of malpractice. One is duty to care. Doctors have a duty to care to their patients. The second one is breach of duty to care. So if a doctor doesn't demonstrate duty to care, that's malpractice. If a doctor demonstrates breach of duty to care, that's malpractice. If a doctor doesn't follow standards, okay, that's malpractice. There's a 4th one that escapes me at the moment. Okay, the regulatory is here in the United States or in Israel and every country, there's usually a regulatory body that oversees doctors. And when patients have complaints, they can complain to the Board of Medicine of Florida or the Board of Medicine of Pennsylvania, right? So I believe that the duty to care and the breach of duty to care and the damages, that's the 4th one, damages, okay, can all be held to a commercial standard. Just like doctors are held to that standard, you could hold your technology to that standard. The technology has to be up to date, it has to work properly, it has to demonstrate accuracy. And from a regulatory perspective, you could have the boards have experts in AI in every board that oversees the technology and make sure it's okay. And of course, we have the FDA and other regulatory bodies that can oversee to make sure that the product does what it says it does. So we can overcome the regulatory and the malpractice issue. And it's not like there's not a whole slew of malpractice going on already. We can definitely overcome the malpractice issue. Okay? So now is the question, will AI replace doctors? And the answer is not so fast. Not only because it can't examine the doctors, but there are some people that will pay a premium for the human touch. Okay? There are people who still pay travel agents to make their travel arrangements, while most of the world does it on their own. And that's where concierge medicine comes into play. A concierge doctor here in the United States is usually somebody that had 2,000 to 3,000 patients and got rid of 3/4 of those patients and is left with maximally, typically 600 to 800 patients, minimally 200 to 300 patients, and they'll charge $2,500. So imagine if you have 600 patients and they each pay you $2,500, that's $1.5 million before you see that patient and bill them for anything else. And guess what? They do see those patients and bill their insurance for everything else. Those doctors are working presumably less hard with 600 than with 2,000 plus patients and getting paid at least 2 to 3 times as much as the doctor who sees the 2,000 plus patients. Why are there not more concierge doctors? Because there aren't enough people willing to pay them the $2,500. But my next door neighbor, who is a dentist with a PhD in epidemiology, wasn't feeling well and went to the local hospital, and nobody would pay attention to him, even though he was in terrible pain, and it turned out he was going into septic shock. And finally, they took care of him, but not before he suffered terribly. And he came home and he said, I'm getting myself a concierge doctor. because I need somebody to be championing me in the emergency room, making sure that somebody's paying attention to me and taking care of me. And when I heard that story, I've been my own doctor for many years. I said, I'm going to pay $3,000 to get me a concierge physician because I know exactly what he's saying. I don't want to go to an emergency room and somebody pushes me to the corner. Now, I've been very good in emergency rooms being able to tell my story in terms that make sure they pay attention to me. In fact, many years ago, I went into something called atrial fibrillation, and they wanted to dismiss me from the hospital without even working me up. And my brother Shlomo, who was alive then, and was a cardiologist, said, tell them the following. Tell them that if they release you from the hospital and something happens on the way home, like you crash the car because you go back into AFib, that you want the record to reflect that they sent you home without working you up. And after they had told me for hours there was nobody to see me and the electrophysiologist couldn't come, he was very busy. Within 20 minutes, the electrophysiologist was at my bedside, and within 15 minutes of that, I had an echocardiogram because I scared them. So I'm pretty good at scaring people and doing what I need medically. But I said, you know what? I'm willing to pay $3,000. So when I walk into the emergency room, there's somebody there fighting the fight for me. But that's really bad for everybody else because every concierge physician gets rid of 3/4 of their patients who have to go find new doctors. And by the way, I tried looking for a regular doctor before I went to the concierge. I couldn't find one in Boca Raton, Florida. So the answer is there will still be human doctors, but only the wealthy will be able to afford them. Everybody else, I believe, will be relying on the technology, which will be smarter than the human doctor. And the human doctor will be using AI because it'll be malpractice not to use AI in the future. But that's what's coming. Whether it comes in 5 years, 10 years, 15 years, I can't tell you. It depends on further technological breakthroughs. But AI can do many, many interesting things. It can reduce wait times. It can improve clinical documentation burden, okay? It can interview the patient and document it. For example, Soap Health's product can complete 90% of the patient encounter. Think about it, 90% of the patient encounter before the patient walks in the door. The only thing left is for the doctor to do the physical exam. And we are building and hope to complete by September the world's first AI-powered primary care provider that will do everything a telemedicine doctor does, but better. Again, the only thing we won't be able to do is the exam. But what we will be able to do is recommend testing, process test results, even recommend treatment. Everything a human doctor does in telemedicine. What is the key to success with AI? As Captain Jean-Luc Picard of the Star Trek fleet, make it so. Now, the key for AI to work is to understand change management. We as human beings are scared of AI, maybe because of the Terminator movies, maybe because we don't understand it. And so in order to affect change, you need to go through a process. And this is a proprietary process that Soap Health has built. 1 second, I'm trying to get rid of this here. Okay. Organizations are like human beings, they're complicated. And you have to basically work through the different aspects of change management in order to effectively bring about change. You need an implementation roadmap from budget to proof of concept to pilots to assess, gathering feedback along the way, improving along the way. The do's and don'ts. Don't leverage do leverage AI for decision support. Don't over-rely on AI. Validate AI insights. Neglect human intuition. You all probably know about Kahneman's two systems. Use system 2, not system 1, when it comes to diagnosis. Maintain human oversight. Again, that oversight doesn't have to be a doctor, but it has to have human oversight. Do not blindly trust AI outputs. Let's skip that. Key progress indicators. The most important indicator to me is patient outcomes. But in order to sell it effectively, you must have efficiency gains, make sure there's a financial impact, and it has to positively impact quality of care. Here is a case study that points out the power of an AI interviewer. An 18-year-old woman walked into a clinic in South Florida. She told the doctor that she had been having headaches on and off for several days. She told them that she gained some weight. He didn't bother to ask how much because she was obese. She told him she had some anxiety. She told him she had some family history of diabetes and high blood pressure. Based on his intake, he wrote, referred to neurologist, because he didn't know what was causing the headaches. The nurse who did the triage collected similar information. Unbeknownst to the nurse and the doctor, there was a pilot underway. She had been interviewed by Jeannie just moments before she saw the nurse and doctor. She told Jeannie that she gained weight. Jeannie asked how much. She said 15 pounds. Jeannie calculated her BMI with her height and identified that she had crossed into obesity. Jeannie identified that she had significant anxiety. Jeannie identified that her father and grandmother both had developed diabetes in their 40s. Jeannie identified that her headaches were concurrent with sexual abuse, which she shared with Jeannie but did not mention to the nurse or the doctor. Based on this new information, the doctor referred her to a mental health counselor instead of a neurologist. And the diagnosis system flagged that she was at increased risk for polycystic ovarian syndrome. It also flagged that she could have a pituitary adenoma. It also, the risk assessment flagged that her relative risk for diabetes had gone up 450% because she had a first and second degree relative with diabetes, and she had a BMI above 30, and that her absolute risk for developing type 2 diabetes was now between 30 and 70%. All missed by the doctor, all caught by the AI interviewer and risk assessment system. And with that, I'm happy to take any questions.
Thank you very much, Stephen. So you can stop sharing. And so you can already start raising your hands if you want to ask a question. Just push react, and then you can mark raise hand. And while you're thinking of raising your hand, so I'll just say the following. So I try to kind of put the main points that you mentioned. I'll just say some of them so that people have in mind what they want to ask about potentially. So you referred to the human limitation that medical doctors have. You related to memory, to cognitive load, and maybe fatigue that relates to working a lot of hours and so on. You talked about how maybe intuition is something not to give up on, but maybe relying on our abilities, our cognitive abilities is a problem, and maybe AI should have something to help us with. You talked about bedside manners and professional comportment, and kind of looked at how it's important for people to have that with their doctors, and how potentially digital agents might provide that in some sense because of the time that they have and the patients. You also mentioned, in a way, although we didn't discuss it, and we may want to discuss it now, lack of access to health in most of the world. So the discussion that we usually term global health ethics might be relevant if we want to discuss this aspect. And you mentioned, you called it duty to care. We usually refer to it as duty of care, which is a part of the negligence field in medicine, or damages. And I think we might consider how this could be interpreted in the sense that who is having this duty and who should bear the responsibility when things go wrong. And what you refer to as concierge medicine might be a bit different in other medical systems. I think maybe the parallel in some countries would be private medicine versus public medicine in a way. And before I ask any question, I would like to open this for debate. So we have some people with questions. Felix, please.
Hello. Thank you very much for a great conversation and lecture. It was really insightful. Dr. Stevens, do you heard about CPI of Clalit services? It's like a personalized predictive medicine using AI softwares. Have you heard about this? Do you think any collaboration with this? Is this the same, maybe working the same platform? Or,
First of all, I'm a super collaborator. I believe in working with everybody and anybody if it will help my mission of saving lives in memory of Shlomo. Okay, by the way, I made my fortune already. I don't take any compensation. I gave my stock to my children. I'm on a mission to save lives, pure and simple. Right. I kill myself to save lives. That's all I care about. So yes, I will collaborate with everybody. But my thing about prediction is based on statistics. And by definition, it increases the risk of missing something important. I have received grants from both the National Cancer Institute and the National Health Service, just got over $3 million from the National Health Service in the UK to improve early cancer detection. Okay, using a combination of better data collected from the patient and data available from other sources to create and identify early markers of disease, not just blood markers, but life markers of disease. So yes, I'm very interested in collaboration.
Can I also mention there is a organization called CEPHAS. It's national project that collect blood test sample, and it can demonstrate if you have any hidden future genetic problems. So it's also can be very.
I'm also very interested in genetics and polygenic, both monogenic disease and polygenic risk scores. I've been studying that religiously. I'm also very interested in primary prevention. Okay, and I'll give you an example. 80% of lung cancers develop in smokers, but only 1 in 5 smokers develops lung cancer. If we're going to focus on preventing lung cancer, we should identify who that 1 out of 5 is and put all our energy into them as opposed to the other 4 out of 5. Yes, they get COPD, they get emphysema, but they don't get lung cancer. And so we have to identify who gets what disease, why, when, how. Yeah. That's what I call that precision prevention. We don't have precision prevention. That's what we need.
Yeah. Now we're going to kind of shift our focus to ethical questions and responsibility-related questions. Now, so first, if other people want to raise their hands, then you're welcome to do it. And I want to just refer to just one example of, let's say, even a technical issue with the case that you presented. So if I present a patient, I allow her, in this case, to talk to the agent, and she gives information to the agent, then I would expect and assume that when she also talks to the nurse and to the doctor, she may not have the same energy to repeat the same information again. It's kind of how we feel with the healthcare system, that people keep asking us the same questions and expect to get the same answers. I see that with patients that we need to reevaluate every time in psychiatry. So obviously the situation might change over time. You want to see that, but you can see how that burdens them because they already know what you're going to ask and they know what you're expecting them to respond. And in a way, they feel like, well, nobody really cares about me. They just want to go through their, routine questions in a way. So isn't it a possibility that the genie received information because it was first to ask the question?
Yeah, look, it's absolutely possible, but it's also very well known that people don't disclose that type of information, very intimate, very personal, very embarrassing information to human beings because they're afraid of how they're going to be judged, right? A doctor or a nurse might say, well, you don't take care of yourself because you're obese, okay? And that's why it happened to you. I mean, the human brain has the ability to rationalize. In that particular case, absolutely. But here's the reality. Our interview is better than the human interview. Why? Because the human interview is 15 minutes and our interview does an exhaustive interview. But here's the beauty. After you do this one time, the other interviews are less than 5 minutes because it's just a question of updating.
So in a way, we have with us, everybody, by the way, at this point, you're more than welcome to open your cameras. We'd like to have something as similar as possible to a seminar where people could see each other. That's why we're not doing it as a webinar. And we have with us some medical doctors here of different fields, and we have different people from the mental health field. So please, I'm sure you have a lot of thoughts. I see Vered, you open your microphone, please. You're welcome to share your thoughts.
Can I ask a question? It's not exactly medical, it's more the technical. Such an interview, how long and where is the data stored? How do you protect it?
Stored in the Google Cloud.
Yeah, but the question is not just the where. How is it protected? Does the client allow it to be kept for a year, forever? Who can view it furthermore? There are a lot of aspects that maybe you don't want to share the data with everyone, maybe only with your physicians or so. These are issues to be taken care of.
Yeah, look, I'm in the camp that, and in fact, I had a slide there from one of my other presentations about helping as many people as possible. I believe that if you're part of a public health system, your data should be anonymized, but should be available for research and other purposes. Okay, because that's how we're going to find and cure diseases early, by having enough data and detail about millions, if not billions of people, and seeing who develops what, when, why, what genetic profile, what lifestyle profile, what ethnic profile, et cetera, et cetera. From my perspective, again, I'm not focused on making money, which is probably why I'm so slow in making money, even though now we're making money. But my point is, I am focused on eliminating misdiagnosis from medical practice across the globe. Period. End of discussion. How do we get the right diagnosis every time if it's possible? You can't get the right diagnosis every time because it's not possible, right? Sometimes you need a biopsy to get the right diagnosis. Okay, sometimes you need a genetic test to get the right diagnosis. Sometimes it's impossible to get the right diagnosis because it's never been diagnosed before. But the point of the matter is, we shouldn't be subjecting human beings to 5 to 15% or more error rates.
Right.
That's the problem today.
All right, thank you. So we have Vered, then Lina, then Ran. Vered, please.
First of all, thank you very much. It was very interesting and on a very big range of topics. I have some critics about the fact that you tie all of the improvements to only AI. It's a computer. Everything that you make a computer a workflow, and you use computer resources, will bring you to the fact that you can reduce time of waiting, and you can reduce time of looking for information. And I would put more emphasis on the AI part of making things better, and less on being more computerized.
Look, we first of all, everything is not AI. The interview starts out with very many hard-coded interview processes. The risk assessments are all hard-coded algorithms. We use AI as a safety net, basically, to make sure we didn't miss anything, that we catch everything, that we considered everything. And again, I can't go into specifics of how we do that because it's basically trade secrets, but we have a brilliant head of our innovation team with PhD in AI, and between he and me, we think about things that nobody else seems to think about, and we keep inventing new things that no one's ever invented. So we have patents issued, we have patents pending. We're building one of a kind, but the reality is not everybody has access to technology in every part of the world, right? But everybody can get to a store where they buy their food, and in those stores there could be booths, and those booths could have the technology there, or in a church, or a shul, or in a community center, or in a government building. So even if you don't have it at home to internet and technology access, you can get it somewhere else where you go for your medical care, where you don't have to see a human doctor. You can still use the technology before the human doctor.
Yeah, thank you. Lena?
Thank you very much. I'm a geneticist, director of Bellinson Genetics Institute, and I wonder how difficult would it be to use the system you created in another language? For example, one of the drawbacks of one of the reasons of shortage of geneticists is that we have to write very, very long summaries, which takes maybe 3 times more than actual genetic counseling. So just taking these summaries and preparing something just to, look at and correct a bit.
Yeah, so we use Google speech recognition, and so we can recognize over 300 languages. We're finishing Spanish right this month, and once we finish Spanish, we know how to do every other language. And so over 300 languages would be possible.
That's for speech. And if you want to go over a database of summary letters and to train the system to create something automatic based on the interview?
So I'm not sure I understand the question, but look, ambient technology can listen in on conversations and create a summary note. I'm not a fan of ambient technology, but it does have that capability. Large language models can translate entire documents from one language into another. People have been working on technology that can hear one language and write it in another language. So all that is possible. From my perspective, I am focused on the clinical encounter, making it accessible and affordable to everybody, and making sure that the right diagnosis, if possible, is obtained.
Thank you. I think I asked you the same question when we talked a few weeks ago, Stephen, because in a way, when you gave the example of speaking to the porcelain god, that might be something that is more culturally related to a certain area in the world and may not be the same in Hebrew or in Arabic, all right? So in that regard, I think what Lena was asking is, okay, so you trained it for 9 years on text from interactions in America maybe, but what would it entail to do the same in another language, another culture, another country like Israel? Would that
what it takes yes, what it takes is basically to go talk to people and say, tell me every way you can think of to describe vomiting, diarrhea, constipation, headache, stomach pain, skin rash, including, Ashkenazi and Sephardic and Arab and Druze. How do they pronounce the words differently? Okay, it just takes time. That's all it is. It's not difficult. If you had 100 people go out and interview 1,000 people, you would come up with 98% of the terms that could be used.
And that's So just a second. And that's actually relevant not only to train a system, in a way, that's also relevant to healthcare providers. That's the reason why sometimes we have courses to, for instance, I don't know, basics in Arabic in medicine, so that people would be able to understand some terms and so on. So that's quite interesting. And before we hear you, Patrick, because Ran raised his hand, so if you can remember your comment and say it after Ran. Okay, Ran, please.
Patrick, you can go ahead if you want. You can go first. I will wait.
Thank you, Ran. I will just make a quick remark and follow up on Lina's question, because we are just around the corner in Schneider Children's developing a use case for automated summary letters based on LLMs. And what we have found is that even if you look at the differences between different pediatric departments, there are differences in style and in various preconceptions that the departments have. So the training data is really crucial. It will reflect cultural differences. It will reflect medical biases that are important to the end user. So I think it's important that the model will be trained on the relevant population to some extent.
Yes, but look, you know, the thing is, it's one thing to train it on the relevant population. It's another thing to decide among a group of doctors, is that the best summary? Okay, is that, I'll give you an example. There's a question that's never asked in medicine, almost. We ask past medical history, we ask past surgical history. You know what we don't ask? Past injury history. Okay, and we know how important injuries, you know, when you were younger or in the military or playing sports could be to your diagnosis today, but we don't ask that question. Okay, we added that into our interviewer because we also said we don't want to just digitize the medical intake. We want it to be a superior intake, asking questions also about travel. Okay, where have you traveled? What did you eat when you traveled there? Did you go swimming in any unusual water? We asked that, we're adding that question for every patient. Why? Because you never know what that's going to tell you that you didn't think of. So my point is, it's not just about culturally removing bias for particular populations. It's also on the medical side, removing the bias that we're taught in medical school. For example, when you hear hoofbeats, think of horses, not zebras. That's great if it's a horse, but if it's a zebra, that's terrible because you're thinking of horses and the person has a zebra. Or the fact that we're taught in medical school, ask the patient an open-ended question. What brings you here today? Would you believe a study showed that 7 out of 10 major symptoms are missed by that approach? By asking an open-ended question. My point is, we have to fix the bias on both sides, physician bias and patient cultural bias.
Thank you, Stephen. You're reminding me of the program Dr. House. So in a way, the diagnostics medicine, right? But without all the quirks and unique traits of Dr. House, the TV character. Ran, please.
Okay, so hello, Stephen. Thank you for this very interesting presentation. I'm from the Digital Health Division in the Ministry of Health in Israel. And my question is regarding the large language models that you are using, I think both in your AI agent and I think also in the summarization, right? In this, when you summarize the...
We don't summarize.
You don't do this.
We present we present all the data that's collected. We don't summarize because we don't trust the large language models to summarize.
Okay. So when you use it in your AI agent, so what kind of guardrails do you have for inconsistency, for bias, for hallucinations, for this kind of things that we can see from these kind of models?
Yeah. So without getting into trade secrets, I will tell you that we test our models, first of all, on real world case studies. Okay. And you also have to be careful when you use real world case studies that they are not case studies that are from 2023 and earlier, because the models themselves may be trained on those case models. So you have to use very recent real world case studies. 2, you have to look at things like even the order by which you put information in affects the model. So you have to use your prompt engineering, and you have to keep iterating and testing and testing and testing and testing, which is what we do every day. We're testing the model against real world case studies, and we're tweaking the prompt engineering to make sure that the responses we're getting. At one point, we put into our application the ability for the large language model to identify if the medications could be the cause of symptoms. It hallucinated, and we had to take it down. Okay, so even after exhaustive testing, it's still, so now we do far more exhaustive testing to make sure that it never hallucinates. Plus, again, it's trade secrets. We require the large language model to provide information to substantiate the information. I can't go into more specifics about it. A smart person probably will figure out what I just said, but the point of the matter is it's almost like judo. We're using the large language model as a leverage against itself. And we just discovered a major breakthrough this week that I can't go into, of how to make the large language models have greater capabilities, because the big issue in large language models is that you don't know what databases they're trained on. Okay? So if you're expecting it to answer a question, it can only answer the question based on the database that it's trained on. If you can identify what it's trained on, which we've been able to do, so we know where its healthcare data is coming from because we look for matches, we're then able to do things to overcome weaknesses. Let's put it that way.
Right. Now, you talked, so Stephen, so you talked about basically hoping to have a superior agent to the medical doctor while having a person in the loop, and not necessarily replace the doctor, but maybe filling in the gaps where medical doctors don't have enough time, energy, or patience, maybe even to hold a very long interview and so on. And then you mentioned the duty of care. You mentioned reasons for medical negligence cases, and I want to maybe for a minute focus on that. So usually in the Anglo-American legal system, when we talk about negligence, we talk about four elements. And the first one is that there is a neighbor relationship, or something that relates to proximity that creates a duty of care. This proximity is not necessarily a physical one, but if I am your neighbor, then maybe I should not make noise at night. And if I am your medical or healthcare provider, then I have some duty of care towards you, right? And if I also breach that duty, and the question is what would be considered a breach of that duty, and if that led to damage, so there is causal relationship between my breaching of duty and your damage, then I would need to pay damages, okay? Now, so I guess the question is, if we're talking about the duty of care, if you're providing, I mean, you presented your company and your product, and although we want to have a general discussion on responsible AI, we also brought you as a person who developed something and who believes that this product could save lives, and I really relate to your sentiment. I think it's great that people do something out of passion and not just out of other considerations. I think it's important in this kind of work. Now, so the question is, once such a system is used, can I come and complain, look, I consulted with your system and this led to maybe misdiagnosis, maybe partial diagnosis, maybe I don't know what. Being superior and all, should the company that provides it also have some responsibility or liability? Should only the medical institute that uses it should? I mean, it's not fair to ask you that, right? But in a way, if it needs to be superior to a medical doctor, who takes the responsibility and why?
So let's break it into two questions. If it's completely autonomous, the company that provides the software should absolutely be held liable. Now, that company, again, should have very clear guidelines. It should be FDA approved. It should have been clinically validated in studies. Its capabilities should be publicly available. It should have caveats and waivers and so on and so forth. But if it fails to meet its duty of care and breaches it, if it clearly is responsible for the damages, I believe, yes, it should be held responsible. But
Okay.
so everything is held responsible and anybody can be sued anytime. So I don't think it's anything new. Okay. Plus, patients who don't agree with it should raise issues. Look, we just introduced something into our digital human introduction. When she introduces herself, she now says, I love feedback. I love feedback. Give me all the feedback you want. 3 or 4 weeks ago, we had a patient complain, very big complaint. Okay, complained to the doctor complained to us. What did they complain about? We asked a question that said, was this disease the cause of your uncle's death? And the picture that accompanied that was a tombstone, a kever, a great, a machpelah, okay? And the patient was triggered by that.
Right.
So we replaced that picture with an empty bench sitting on a hilltop facing a setting sun for that question,
So,
right? So people can complain about anything.
Right. So it seemed insensitive, and although it's a computer, people felt that caused them to feel unpleasant. So in a way,
if there's a doctor in the loop, then the ultimate requirement is on the doctor to make the judgment. That's why we don't call our differential diagnosis differential. We call it reference diagnoses. But here's what a study showed out of the UK. If you give a doctor a differential diagnosis, you will improve their diagnostic accuracy by 8%. So let's understand, if they're accurate 90% of the time, by showing them a differential diagnosis, you will make them accurate 97.2% of the time.
Even if they do not agree with it, so you say, do they always
just giving them a related differential diagnosis was studied by Olga Kostopular at Imperial College UK, and she published that improves diagnostic accuracy by 8%.
Right. So in a way, it's consulting a colleague, in a way, a digital colleague, and then considering whether or not I agree with the conclusions or recommendations of the colleague. Now,
let me give you one more example about AI in radiology. It is known that 30% of radiologists don't agree with each other. 20% of radiologists don't agree with themselves. In other words, when they review an X-ray, they change their mind 20% of the time. Okay? It's also been shown that one radiologist using AI is 20% more accurate than 2 radiologists without AI. You know what percent of radiologists use AI? 2%.
Right. Well, I do think maybe radiology is one field that is not necessarily similar to others, but that's a really interesting point. I just want to kind of finalize the issue of responsibility, and then I see, yes, I see somebody raising their hand, so in a minute. So just to finalize the issue of responsibility or liability, so in a way, so we mentioned the duty of care. Now, in a way, to hold the duty of care, necessarily you should usually talks about a person, right? So in a way, even to be providing medical advice, I need to be a medical doctor or to have a profession. So in a way, what happens to the license to practice medicine, right? So in a way, I think in many countries, there's still not clear ability to allow an agent to perform the work of a doctor. You said replace the doctor, but then the regulation talks about who has the right to practice medicine. I don't think it includes digital agents. So in a way, until this is changed, it doesn't seem to be even a possibility that a digital agent would practice medicine. So the question is, what can it do, right?
So it's going to come down to the science. It's going to come down to demonstrating beyond a shadow of a doubt that the digital human is more accurate and reliable than a human. And once you prove that, then you could go down the regulatory approval process. Look, here in the United States, I'll give you an example. In Florida,
okay, we're experiencing some connection issues. Let's hope Stephen reconnects to us. But I see other people are still connected, so let's hope he can reconnect. I can just maybe continue that. So you could hear Stephen calling it the digital human. And that actually connects to, oh, so Stephen, you were kind of disconnected for about a minute. So you can resume what you started to say, but I just say that while you were out and not connected to us, I said that you used the term digital human. I don't know if you did that just like by accident or you meant this term.
Yeah, well, digital human, embodied AI, virtual being, relational agent, it goes by many different names, okay? I often use digital human because it's a digital human. Our character is actually a person on a screen that talks to you. She moves her hands, she moves her mouth, she goes like this, like this, like this, you know, she's like this, like that, you know,
but this connects to something interesting because, so, you know, in philosophy, there's the concept of anthropomorphizing, which means referring to a non-human
yes.
as if it were a human. Now, in your talk, you actually referred to a kind of a dual concept. On the one hand, we want it to be pleasant, we want it to be considerate, not to show any kind of images or use language that might be triggering and unpleasant, and to tell us in words that sound human, I'm interested in your thoughts and whatever. At the same time, you mentioned that it's good for people to know that this is a digital agent, it's not going to judge them, and they'll feel more free to talk to it, and I'm saying to it and not to it, her or him, in a way that they feel more protected. So you're kind of holding both ends of the same spectrum. So how do you solve this?
So you don't need to solve it because the user solves it. The user can decide whether they want to talk to the digital human or they don't want to talk to the digital human. So it's a personal choice. And the digital human, I from day one did not go with just a talking head. I built the whole body. Why? Because it's like Zoom. If you're staring at somebody's head the whole time on Zoom, then you're focusing on every imperfection in their face and their head and their hair, their nose, their eye. I don't want them to be focused. I want them to feel like they're talking to a person, but they know for sure that it's not a person. Also, at one point, Jeannie says, you can ask me anything you want and no one will know. And we don't track it and we don't save it. And one person asked her, are you wearing any clothing? And he was shocked. Okay, he told us when she responded, you know, that's an inappropriate question, right?
So you heard it from the user, but you really didn't get the information from the system. Is that correct?
Correct. We don't track the conversation between the human and the system when they're just having a conversation.
Interesting. And
just between
interesting legal and other questions. It's like a digital wailing wall. So Dr. Greenspan, please.
Yes, thank you. Thank you. So I hope it's okay, Owen, but because Stephen mentioned radiology, I do want to ask a quick question about imagery because that's my field. I'm a professor in medical imaging and I work with AI for many, many years. Actually, I joined a partner who is the head of radiology at Sheba 10 years ago. We founded a startup in the field of bringing tools to radiologists. Okay, and I've been exploring this path for many, many years since. For the last 3 years, I've been sitting with Mount Sinai, trying to bring AI into the hospital setting. So I've tried many different aspects. I found your summary here fascinating. I agree almost every word you say. But I want to ask you specifically from my experience. We built a virtual resident. That's the way we called it. It would look at the images coming in and build a preliminary report as if it was a resident, saving time, misdiagnosis, et cetera, et cetera, et cetera. FDA did not like that concept. So the first issue we encountered was FDA. It's still true to date. FDA is making the progress very, very slow. Each indication we have to spend, a company needs to spend millions of dollars just to get one small finding, and the radiology report has many. Basically, we're very, very limited. The second question is, on the business level, it turned out no one was willing to pay or interested to pay for radiology support. So I'm curious who you're finding that would actually pay. And it's not my own experience. Basically, all the radiology startups were a big hype. and 80% of them have closed down since. So,
Yeah, so let me tell you, it's a great question, and I'll tell you what the answer is, and it's a very clear answer. You don't sell it to the hospital or the medical practices. You do what one company in the US is doing. You hire your own radiologists, they use AI, and you sell the radiology service to the hospital that doesn't have radiology or doesn't want to hire more radiologists. That company is generating tens of millions of dollars by using AI internally. And that's a trick. We have been very fortunate in that we've already, in the last 2 months since we released it, we've signed up over 30 medical practices because doctors are literally saying to us, thank you for building this. We're getting thank yous. And 80% of the doctors we have done demos for have signed up. 80%. So we're getting a very high success rate. Why? Because they know they're in control, and we sell it to them not as the AI, we sell it to them as something that will increase productivity, that will make them more money, reduce no-shows. And you can't tell the doctor it's going to improve diagnostic accuracy because they all think they're great diagnosticians. So what do we say? You'll make the diagnosis faster.
Right, we've tried that as well, but I appreciate your ability to do so. But do you have to pass through an FDA for the LLM kind of
Well,
field?
interesting enough, I wrote something on LinkedIn and it started a whole firestorm. People telling me I need FDA approval. So what I did is I'm part of a program in the NIH that gives me access to the FDA. I just wrote the FDA a long letter outlining exactly what the product does and how it does it. And I asked the FDA to tell me whether or not I need their FDA approval.
Right.
Okay, open question.
So
By the way,
Thank
I'm
you.
coming to Israel September 15th. I'm going to be there for 3 or 4 weeks. If anybody wants to meet with me, wants to collaborate, my email is scharlap@soap.health, HEALTH.
Yeah, we'll share that with the people who participated and registered. And I can just say that what you just suggested here, Stephen, refers to the fact that we're talking about a new field. I mean, the regulation of AI is still kind of discussed in different countries and areas in the world. And in this regard, you offered some ways to kind of deal with the current state of affairs and regulation and to find ways to work around or work with what's already in place. And I think it's probably going to take time because there is some reason why regulators are not that quick to regulate in this field. And I don't think it's because they're so against progress and saving lives. I think there are a lot of small issues that are hard to define and are hard to kind of operationalize to a law that one could say that is good enough to be to be used. So in a way, there's a sense of using what we already know, and I think it was very creative what you suggested. In a way, if that works, for instance, if people are, but you're saying you hire your own radiologist to use this, and then the question is, are these radiologists even allowed to use this in their practice? Because in a way, if it's a medical device, it needs to be approved. If it's a decision support system, it also needs to have, I mean, they can always say, it's like reading a book. You cannot tell me which book I should read. So it's really something that, I mean, as a jurist now, I'm thinking there are different ways to define it. But clearly, somebody working in a public health or in a public system would be very careful with adopting a digital tool that is external to where they work. And what you're suggesting might have some impact, because if it's shown that these doctors working with these tools are far more efficient, quick, and so on, then this will probably over time convince more conservative or big institute or centers to adopt it. So this was an interesting approach. So we have kind of reached the end of our hour and a half, and we'll let you all know about our next meeting. So we'll send the information. Thank you everyone for joining us. It's nice that we had an hour and a half that were quiet in our area, and looking forward to seeing you in our next seminar. Goodbye.